to meet the colleagues from the University of Sunway. And yeah, it's so good that you are going to record the meeting. It's really great. And yeah, thank you, everybody. If you like me, I'm going to share my screen with you.
So thanks. Student track need to be responsive, okay?
Okay. Just after saying thank you and to express my excitedness with you guys and Professor Lang. As you mentioned, my name is Mostafa. I have a PhD in epidemiology from Maastricht University. I have this honor of working with some top institutes in the world, like Global Burden of the Disease, Maastricht University, with your university, and Shiraz Medical University. This is just right after 5 years. My H-index stand at 35. I have several publications, like as Professor Lungs just mentioned, in the Lancet, in JAMA, and many other journals. Currently, I am the editor of PMC Cancer, PMC Public Health, and Frontiers in Public Health. So feel free to submit your papers and keep me updated if you have submitted your paper to one of these journals. So maybe we can fasten the process of your publication. By the way, can you see my screen? Everyone?
Yes, also, Prof. Liu, our professor of public health, also here. Hi, Prof. Liu, if you have and just feel free to unmute yourself, Prof. Liu.
Yeah. Hi, Mostafa. Welcome, Dr. Mostafa. I'm Elil. I'm working remotely today, but congratulations. We're pleased to have you on board. I don't want to disturb you. You've got a good group of students, and sorry to step in at this point. Please continue. Thank you.
Thank you so much, Professor Ali. Pleased to meet you, and thanks for being with us. Actually, before get started, I have some questions for you. As a researcher and a student, if I ask you for each topic you chose a study design, which study design you will go for? For example, you are going to examine COVID-19 mortality and clusteral intake by countries. Here, as you see, you don't have any individual in your studies. It means your sample size is countries. Here, factor related to breast cancer delay diagnosis among women. Which study design you will select? For example, you are going to check neonatal COVID-19 infection in China. As you see, this is like a rare disease. And if you are going to examine stunting and its associated factors among children in Malaysia, which kind of studies you would go for? Another topic, if you are going to examine the effect of different treatment strategies on the survival of patients with cancer, which study design? Also, the association, for example, between meat and fish consumption and bladder cancer risk. Another research topic, if you are going to examine the effect of immunotherapy on the progression of advanced triple-negative breast cancer, or the effectiveness of COVID-19 vaccine in reducing the incidence, hospitalization, and mortality. And finally, if you are going to examine the global and regional prevalence of hepatitis C in HIV-positive prisoners, which study design you will select? I'm so glad to let you know that these topics and these basically titles will be our main concentration about study designs. My objective at the end of this lecture would be you will completely be familiar with study designs, with epidemiology, study methodology. You will be familiar with classification of epidemiological studies. you will be able to make distinguish between different study designs. In today's lecture, you will be really good familiar with cross-sectional studies, case report, and ecological studies. And also today, you will get some knowledge about case control studies and a bit about cohort studies. And finally, today, I will finish with some challenges and benefit of using each studies. In the next session, next week, I will delve into the cohort studies in more detail. I will open up for you experimental studies and RCTs. I would like also to open another door for you and to discuss meta-analysis and systematic review analysis for you. And finally, I will finish this lecture with some key points in each study design. To be honest, when I was asked to present this course to you, I was like, yeah, maybe I'm gonna do a magic, because to me, presentation of epidemiological designs in just 2 sessions, yeah, it's you know, not possible, but I try to do my best for you, and hopefully you like it. Okay, the material that I mainly use for this course basically are Gordis epidemiology, as you see here. And I would recommend everyone, not only epidemiologists, a student of public health, and any medical related subject, please read this book carefully. And I also tried to include this really valuable textbook in epidemiology, which is Beyond the Basic Epidemiology. And also for some examples, I tried to just show you some of my publications. By the way, if you have any questions, or if my instruction may be not clear for you, please feel free to interrupt me and ask me any question that you may have at any point. So it's completely fine. Okay, as you see here, hierarchy of study designs, you can see a study can be started from an idea or opinion or any letter to the editor. Then we will go forward and maybe we can write a case series or case report. I will open up all these categories for you, so no worries. Then we can go for cross-sectional studies, case control studies, cohort studies, RCTs, and systematic review and meta-analysis. I have a question for you. Can anyone let me know, please, which studies are the robust one and the strong evidence can be driven from which study design? What do you think? If you would like to let me know, please raise your hand. Okay, so as you see in this figure, the hierarchy indicates the relative weight that can be attributed to a particular study design. Generally, the higher up a methodology is ranked, the most robust it is assumed to be. So if you go for a cohort study, RCT or systematic review and meta-analysis, you will have most robust evidence to present to the scientific committee. Okay, as you see here in this slide, we have several different types of epidemiological studies. They can be experimental or non-experimental. So for non-experimental studies, we also call them observational studies. Observational studies, sometimes we have just populations, the general population or a country as our sample size, like ecological studies that I will show you in the next slides. And also we can have observational studies with under category individual-based, like descriptive studies and also analytical studies. Bear in mind that descriptive studies like case report and case series, and analytical studies are mainly cross-sectional studies, which we also call them prevalence studies, also case control studies, and cohort studies or follow-up studies. On the other side, you can see experimental studies or interventional studies. In this category, we have randomized or controlled trial studies or non-randomized studies, quasi-experimental, field trial, and community trials. Yeah, I would like to ask you, please, to feel free to take a screenshot from this slide, or maybe to take a photo by your phones. And because I'm going to ask you several questions, and you can simply have a look at this slide. Okay, so let's move to the next slide. In epidemiology, we have descriptive versus analytical epidemiology. In descriptive epidemiology, as it is obvious from the name, we mainly address to some question about who, what, when, and where. But remember, here we are not going to ask what happened, why, how it was happened, and something like this, okay? If you are going to address questions like why, how, the reason, then this will be analytical epidemiology. I hope it's clear for you. If not, please raise your hand and let me know. I will repeat. I have some chats here. Okay. About analytical epidemiology, we mainly use them to identify the cause of the disease, as I just mentioned in the previous slide. And also, we mainly conduct these analytical epidemiology to approve our hypotheses. So there are two main categories about studies, mainly experimental and observational. Do you have any idea why we call them experimental or why we call them observational? Anybody? Please let me know. I would like to hear from you why we call them experimental studies and why we call some other categories as observational epidemiology. I'm gonna open the chat if somebody. So yes, Camila, experimental, because we are going to experiment. Great job. Good, good, good. Yes, happy to hear from you. Happy to hear. Please remember, from now until, I don't know, when, maybe until the end of your life, the end of your academic life, remember that for experimental epidemiology studies, our exposure is under your control. It means you can manipulate the exposure. Okay? So here you may ask you, so can I do experimental studies using smoking and cancer risk? Definitely not. This is not under your control. You cannot apply such an exposure to the society, just to say some people, yes, you can become a smoker and you are not a smoker. And then because this is my experimental study. So this is not logical, not ethical. In this case, we have to go for observational studies because exposure status is not under your control. So bear in mind, experimental studies, exposure is under your control. Observational studies, on the other hand, you don't have any control over the exposure status. Is that clear? I hope it is. Perfect, 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 perfect. Perfect. Talented students, glad to be with you. So for observational studies, we have descriptive epidemiology studies and also analytical. For descriptive, we have case reports and case series studies. But on the other hand, for analytical epidemiological studies, we have cross-sectionals, cohorts, and case control studies. Let's move to the next slide. Okay, for case report studies. Yes, no question. A case report is documentation by a medical professional or like by a doctor or by a specialist that delve into an exceptional medical condition observed in a single individual. Unlike other research methods, the population in focus is often unknown. So the population under study is really unknown. Also, this making reports valuable when we see weird and unexpected situations. So in this case, we are going to describe the clinical findings that we found really interesting and really rare, unexpected. Here, as you see, maybe you have only one patient, two patients, or sometimes 10 patients. Okay, it's fine. As far as you are going to just describe each patient and there is no comparison group, this is a case report. In your analysis, you may not be able to go for statistical analysis. Mainly, we are focusing on our observations, like any lab reports, any biopsy reports, any, for example, chest X-ray report, and so on. And interpretation of these results are mainly observational. I found this really interesting publication in New England Journal of Medicine. Normal plasma cholesterol in an 88-year-old man who ate 25 eggs a day. So ask yourself, is that okay?
வீட்ல இருக்கேன். ராஜா மாமா பையன் சாப்பிட கூப்பிட்டாங்க. So போய் சாப்பிட.
Yeah, please mute your for the students forgot to mute
SS
yourself.
15ல ராதா அப்படின்னு ஒரு கடை. நல்லா இருந்துச்சு. ராதா அப்படின்னு. இப்ப கிளாஸ் ஓடிட்டு இருக்கு. எங்க?
Can you mute? Can you mute?
Anyone, do you have any question for me?
Yeah, I think so far very good, Dr. Mostafa. Thanks.
Okay, perfect. Because I heard some voices. I was wondering maybe there is a question, but it's not in English and somebody is going to translate for me. But yeah, thank you. Thanks for letting me know. So
I can translate for you, Dr. Mostafa. She was talking about going to have some food.
Okay. Do you think I can proceed now, or we have to wait? Or
yes, please. No. You proceed. I was just joking.
Okay.
Yeah.
Perfect. Perfect. So let's go. So as you see here, when you see something really unexpected in your society, at your work or during your operation, during your practice, you see something really not normal, not common in the society. If this is one patient, we call it case report. Okay, case report, because only one individual is involved in this study. On the other hand, if there are several people with this case, with this rare case, okay, we will go for a case series studies. So let me go to the next slide. As I just mentioned for you, for case series and case reports, we really do not have any comparison group. You cannot compare your results with any other patient, because this is a really special and specific case. Basically, in the epidemiological studies, we mainly have case report and case series during pregnancy. We have a lot of reports about case reports, during the pregnancy, because there are lots of unexpected outcome that can be happen. These studies are mainly perfect for generating a new hypothesis. So this is the last slide about case series and case report. I hope everything is clear with these kind of studies. As I said, no comparison group, in unexpected situations. There is no analytical assessment, just you are reporting your observations. Let's move on to the next slide. This is about ecological studies. In the beginning of this presentation, I asked you to take a screenshot of the chart, the flow chart diagram. As you see here, ecological studies are type of studies that mainly includes populations. So individuals are not included in this type of studies. Basically, we have countries, continents, cities as one sample. So as you see here, we have aggregation of individuals. So let me open up another point in this type of studies. In this type of studies, we mainly look at the overall incidence, prevalence, occurrence of a disease at a population level. So we really do not have any data at the individual level. I have a publication about COVID-19 body mass index and cholesterol using global data. It means I didn't perform any analysis on the patients or on the single individual. I just gathered the national data, I pulled the data, and I reported the data. So in ecological studies, no individual is included, and our population and sample size is the whole country, continent, or the whole city. Okay, let's go to the next slide. So suppose these are, different cities, different continents, for example, or different populations, and you are going to examine the association between cigarette per capita and CHD, cardiovascular disease death. As you see here, no patient or no individual is included. It means, for example, in this city, the cigarette consumption or the cigarette use is really high, and the CHD is also high. Okay, just a question may cross your mind. Really, cigarette in this, for example, in this city is associated with CHD death? We don't know. Let's see. Let's move to the next slide. Here, these are examples from previous publications in top journals. Annual consumption of beer is highly related to incidence rate of cancer, rectal cancer. For example, in Denmark or in Belgium, this is really high. The beer consumption is high, and also the cancer incidence is high. Okay, as a researcher, do you think this is a real association? Can we say that in each country where the beer consumption is high, the cancer also is high? Can we derive this conclusion that beer consumption is associated with renal or rectal cancer? You will see in the next slide. As I said, we use, polled data or aggregate data, which we are going just to generate hypotheses. A really brilliant example in medical sciences is about consumption of dietary factors and cancer risk. So as I said in the previous slide, for aggregate data, we mainly focus on disease rate at country or global level. So no individual is included in this study. This is the top and brilliant publication in the history of medicine. And as you see, this is a really old publication, 1993. It was about relationship between dietary fat intake and breast cancer mortality. As you see here, data for 30 countries were analyzed. And the authors have reached the conclusion that there is association between dietary fat and breast cancer mortality. It means the more dietary fat you consume, the higher chance of breast cancer you may be faced. This is a really big conclusion. Do you think this is real? I'm gonna open up the chat. Okay. Do you think this is real? I have a question for you. Just please let me know yes or no. Data from 30 countries were analyzed, and the author reached the conclusion that higher consumption of dietary fat is associated with breast cancer mortality. What do you think? Any idea? Okay, yes. Jan said yes. Okay, yes. Could be possible, of course. Yes, yes, yes. Remember that. Thank you. Thanks for your collaborations. I appreciate. Remember, we have data for 30 countries. No individual data is included. Your messages are really valuable for me. I'm going to put it here, just in front of my eyes. So let's go to the next slide. As you see here, we have a really big phenomenon in ecological epidemiology, which we call it ecological fallacy. Just have a look at this picture. Have a look at this picture. I'm going to open up with this example. At a population level, mainly we see that male are taller than female. Is that true? Of course. In the population level, this is the true thing that we can see. However, this doesn't mean that in the society we don't have any female taller than male. This is ecological fallacy that we have in epidemiology. In the previous slide, we have reported that higher intake of fat is associated with breast cancer at population level, but we really don't know what is happening at individual level. So one of the most significant disadvantages of ecological studies is ecological fallacy. When this can occur, this occurs when association observed at the population level really do not hold true at individual level. Okay, for example, a study might find an association between high average income in an area, in a city, and a better health outcome. But this doesn't necessarily imply that rich individuals in that society have a better health condition. So this huge problem in ecological studies can be rooted in several cases, and I will open up for you later. About ecological studies, please bear in mind that group data do not necessarily represent individual data. As we just mentioned, fat intake and breast cancer in the countries, because our measurement was country level, I showed you 30 countries were involved. So these two were highly correlated, breast cancer and intake of fat. But look at here, studies at the individual level, like cohort studies and case control studies, have not found any association with fat intake. What's happened? Just we realized that in ecological studies we found association, but here individual studies, cohort study, case control study doesn't show that association, because the source population in ecological studies are a group of people, maybe some patients who already have breast cancer are consuming a lot of fat, but others not. So as you see, ecological studies are highly impacted by extraneous data, by outliers data. If you have outliers data for one country, for example, in 2 cities, the majority of people are drinking a lot of beer, but in some other cities, really not. So we cannot make a conclusion, or we cannot actually see the causality of association in ecological studies. Let's move on to the next slide. And why? Possible reason. Countries with high fat intake are more likely to have other risk factors associated with breast cancer. For example, late age at first pregnancy, which is really common. Or within population, variability is low, but interpopulation variability is high. What does it mean? Actually, I can say that your population at the general level, okay, can be the same maybe, but when you are seeking individual and just doing case control study, cohort study, maybe cross-sectional study, you see the real consumption of patients or individual at your studies. So at a country level, maybe the average that we use is the same, but the individuals, the pattern is completely different. Okay, if everyone in a country had high fat intake, we would not be able to detect any excess, because there would not be any population to compare then to with low fat intake. The point here is that if you have the higher consumption is this country, for example, and in this country, at the same time, the age at first pregnancy is also high, these two are highly correlated with each other. So we are not going to compare these two countries to each other in order to find if this association is true or not. Please let me know if you have any question, maybe. In ecological studies, there are some advantages and disadvantages. These are really cost effective because you can just analyze the huge data from, big data from countries, from registrations, from, like any population source that the data is available, municipality or something like this. These studies are really great for generating hypotheses. And as I just mentioned several times, we look at the population level. Unfortunately, in this kind of studies, ethical consideration is really low because you are just working on aggregate data from different cities. So no individual studies is included. Okay, I have a question. Said that ecological fallacy may be one of the reasons why misinformation on the health is so. Oh, great point. Actually, I have a really obvious example for you in this case. Using an ecological design in a country, I hear that the policymakers made this decision, unfortunately, because it was about diabetes and diabetes prevalence. They realized that the diabetes prevalence in this country is going high and high. So the policymakers decided to really do a really weird thing. This was at a population level, and they fired and they kick out the employees of their public health sector. This is really not joking. You cannot just, make a conclusion from ecological studies and say, yeah, the prevalence of diabetes in this country is going like really high, or yeah, we have to do something about it. No, this is not real. You have to have epidemiological knowledge about, different types of studies. You cannot make a really robust decision about, any changes in the society or on the health of, your society just based on an ecological study. So we have to be careful, and this was a really good question. I would say yes, maybe it can be a reason. On the other hand, okay, I'm not finished here. As I said, this is really good for rare outcomes because we cannot wait in a society just to watch after how many years just we have one case of a specific disease. But if we can have, different countries and we can have access to the data from different countries, okay, maybe we can pull all the data together and make a conclusion. Oh, you're welcome, you're welcome. So as I mentioned, one of the big disadvantages of these studies are ecological fallacy. Please bear in mind this point. So we are mainly looking at, as I said, population data, so no individual data, so we cannot go for generalizability of our data. You cannot make a robust conclusion. You can really not find the temporal association and confounding. Who knows if the patients first, they had breast cancer and then they consume a lot of, for example, fat, or they consumed a lot of fat and then they became sick. We really don't know. We really don't know. So we cannot find the temporal association here. So limited causality inference and confounding. For example, just as an example, I mentioned that in some populations, yeah, the intake of fat is high. But on the other hand, the main factor is late pregnancy, for example. So the late pregnancy in this society is the source of this issue, not the fat intake. So the fat intake is like confounding factors. So let's move on. Okay, let's go to analytical observational studies. Please feel free to take a screenshot of this one. From now, maybe until the next session, I really need you to remember this slide. Really keep it in mind. This is one of the most significant slides that I'm going to present to you. Feel free to take a screenshot. Okay, for analytical observational studies, we are going to compare populations or individuals. We are going to compare individuals. Here, if you compare the individuals at the same time, you look at the exposure and the outcome, you will go for a cross-sectional study. I will open it for you later on. For example, you will go, for example, at the hospital and you will see several breast cancer patients at your ward. And then you ask them about the stage of their cancer, and the stage of their cancer for some of them is a stage maybe end stage 3 or 4, and for some of them the stage of cancer is 1 or 2, early breast cancer. And maybe a question crossed your mind. What happened exactly? Why some patients they diagnosed with advanced breast cancer and some of them with early breast cancer? Then you will examine what happened. Maybe you can have like an interview, like a questionnaire, and ask patient why you detect your cancer so late, why you detect your cancer so early. So you are going to compare two patients. At the same time, you have the patients, you have the outcome, which is cancer, and you are going to see the main reasons for being late diagnosis or early diagnosis. This is cross-sectional studies. It's like taking a photo at the same time. Yeah, this is what was the reason. The second one is case control studies. Guys, I really see that some of the professors at university are making really big mistake in classification of case control and cohort design. They say that if you go from present to the future, this is a cohort study, and if you go from now to the past is case control study. This is absolutely wrong. Guys, if you are going to make a distinguish between case control study and cohort studies, bear in mind from now on, the direction of your study is important. If you are going from outcome to the exposures, is case control study. How? For example, you have some patients with, for example, lung cancer, and some healthy participants, for example, some healthy populations. Like, for example, you have 10 lung cancer patients in the ward, and 10 population, maybe their siblings, their family, they don't have cancer. So you have the outcome here, and you are going to see what was the exposure, what was the reason for becoming sick, and what happened. This is case control study, from outcome to the exposure. So it means you are seeking to find exposures. What was the reason? However, if you are going to start your study from exposure to outcome, this is cohort study. Suppose in your class, there are 20 students, and all of them are having a really, for example, high or low physical activity. After 20 years, Professor Lang will come to assess the outcomes for you 20 students. So we started now with the physical activity, and we are going to see the results of physical activity later, maybe after 10 years, 20 years, to see what happened to you guys. Those who had physical activity, those doesn't have. I hope this is clear. If not, please let me know. This is really important. Do not make this mistake like some really professors in epidemiology that I heard. It's clear. I can move to the next. Okay. Cross-sectional studies. If you remember, this is observational studies under category of analytical. We call these studies as prevalence studies. If you remember from this third slide that I showed you, one of the topics was the prevalence of something in, for example, in this society. This is cross-sectional studies, because you are going to examine the prevalence of a disease or a condition or health problem in your, for example, your city, in your hospital, in your country, or whatsoever. Okay, and here you can examine the pattern of occurrence or prevalence by time, place, and person. For example, you are going to examine the prevalence of like depression in different years, for example, in 2019, in 2020, in 2025, and then in different cities and among different persons, for example, in male, female, or in, for example, young, old population. So the main thing that we are seeing is prevalence. I would like to go back to this question, which was a really good question here. One of the reasons that policymakers are making decisions is not only ecological studies, but also they will go for cross-sectional studies, which is really obvious in almost all societies, except some of them, because these studies are mainly useful for program planning, for stakeholders, for policymakers. They will use these data to see if the prevalence of, for example, this disease is high or low. And then they will allocate different resources, but researchers will generate hypotheses about any association or any significant finding using cross-sectional studies. Just to see time, yeah, everything is going well. Here, I have a question for you. Suppose you are doing a study on diabetes again, and you see in the city, for example, in Kuala Lumpur, the prevalence of diabetes is really high. What do you think? What do you think, guys? This was a cross-sectional studies, and you realize that the prevalence of diabetes in your city, in Kuala Lumpur, is really high. What will cross your mind first? Do you think this is real? Do you think this is a really worst phenomena that is happening? We cannot say that. We cannot say that. I will open this one for you, maybe in the next 2 or 3 slides. So bear in mind, please, for cross-sectional studies, we are just taking a snapshot, taking a photo. You have your patients, and then at the same time, you are looking at the exposure. You are patients, you are not patients. Are you a smoker? Are you not a smoker? So this means at the same time. This is cross-sectional studies. So as I just mentioned, cross-sectional studies start at a single point in time. We don't have any follow-up. We don't have any follow-up. If I would like to write one question for your final exam, definitely I will go for this one, if we do have follow-up in cross-sectional studies or not. So definitely not. Exposure status and disease status are measured at once at the same time. So remember this one also. And we are going to see the prevalence of, for example, the disease among exposed and non-exposed. For example, we are going to see the prevalence of late-stage breast cancer among those who had health insurance and those who doesn't. Let's simply see the design of this study. Suppose in Kuala Lumpur, you have a big population here, and you're going to study, to see breast cancer just in one hospital. So breast cancer patients in this hospital, in this specific hospital under the affiliation of Sunway University, for example, is your target population. Then you will go and grab a sample size from this population, because sometimes it's really not possible to just include all the patients in your studies. It's really time-consuming, expensive, so it's not that possible. Then you are having your population with outcome and without outcome, for example, with end-stage breast cancer and with early-stage breast cancer, and we look at the exposures. What was the exposures? And then we will see the exposures among those who had advanced breast cancer, exposures among those who doesn't have late-stage breast cancer. Then we will make a comparison. If this person has exposure or not, if this healthy or low-stage breast cancer has exposure or no exposure. If it's not clear or if I'm going too fast, please let me know. So exposure and outcome, we are examining both of them at the same time. So let me go back. Okay, so not a big thing that I missed. So in cross-sectional studies, there are some advantages. They are quick, inexpensive, and useful for generating a new hypothesis. But this advantage, we really are not sure about temporal relationship. For example, suppose you are going at a hospital and you see some patients with heart disease. And you will see that, yeah, these heart patients, they are reporting higher intake of, for example, calcium. Okay? higher intake of, for example, red meat. Red meat is a better example. Then you really cannot say that if they first became a patient, or if they ate a lot of meat and then they became a patient. Another brilliant example is this one. In some patients, mainly cancer patients, we say that, yeah, for example, this is lung cancer patient, this is not lung cancer patient, okay? And we see if lung cancer patients are having a high exposure to air pollution. And if not, just let me open up this one for you guys. You will go to the hospital and see some lung cancer patients, and you see, oh, the majority of them are reporting, for example, air pollution in their region or in their city. But you're really not sure if first they were cancer patients and then they were exposed to air pollution, or the air pollution was the main reason for cancer. We don't have any data because we didn't apply any follow-up on the patients. It was a screenshot. At the same time, we saw, the exposure and the outcome. I hope everything is clear for you guys from now. So some examples. You are going to see the prevalence of asthma in school-age children in, for example, Amsterdam. Trend and changing epidemiology of hepatitis, for example, C in Malaysia. Characteristics of teenage smoker in France, for example. Prevalence of a stroke in Frankfurt, for example. As you see, as I just mentioned, these are prevalence studies. And if you read an article and you found that author is reporting there is a causal association between, for example, smoking and higher risk of asthma, do not believe it. Do not believe it, because this is a cross-sectional study. Okay, so we really don't know if this is a true association or not. So if you may remember, just 2 or 3 slides back, I mentioned that suppose in Kuala Lumpur we have a high rate of diabetes. Is it really something urgent and something disastrous happening or not? What do you think? What do you think? So, for example, I heard from one of your colleagues that mentioned the prevalence of diabetes between 2008 and 2020 is increasing about 60%. Do you think this is a worst phenomenon that is happening? It is really bad? What do you think? I would like to hear from you. Yeah, the prevalence of diabetes in your country, in your capital, is going high and high. Professor Il, thank you. Thanks for having you. I really wish you a nice day ahead and hope to see you again. Guys, we cannot make a conclusion about this. The prevalence of this disease in your capital is going high. This is not a bad thing at all. Why? Because maybe we are preventing from death. It means, yes, new cases are coming into our population. It means the population of diabetes are increasing. On the other hand, we have better cares, we have better treatments. So it means we prevent patients to be dead. Okay, so this is not a bad thing. If you see like a high prevalence of something in your society, mainly about chronic diseases, mainly, okay, not infectious diseases, for sure. This cannot be really a bad thing. Maybe this shows the better, health system performance in your society. Okay, we are preventing patients to be dead, and then the prevalence of disease is going high and high and high. Or maybe some patients are going to be recovered. So as you see, we cannot make a really robust conclusion from cross-sectional studies. Just to wrap up cross-sectional studies, data for both exposure and outcome collected at a single point in time. These are the studies for prevalence and the burden of the disease. Here are some publications from me. I will try to share the slides with Professor Lang. So then hopefully you can have access to the publications and simply click on the links and see each study and how I define the design. Okay, there are some points for you here. As I mentioned earlier, for descriptive epidemiology, we answer some question about who, what, where, and when. And then key terms are prevalence, person, place, and time, because these were the main things that we were going to report. And these kind of studies are really good for generating hypotheses. In analytical epidemiology, however, we are going to answer question about why and how, because we are going to examine the associations. Okay, and if you have any question, please let me know. This is the last slide from this part. Then I'm going to move to the next study design, which is case control studies. If you have any question, please let me know. I tried to cover a lot of points here. As I mentioned, honestly, it was like doing a magic for me, because for my students, I always instruct epidemiology study designs, each study one session. But this is going to be a really tough session. My apologies for that if the burden of the new information is really high, but please feel free to contact me, send me email, or just you can type your messages here, and I'm going to answer all of your questions if there is any. If not, I will go ahead and maybe I can start the next session in 5 minutes. Professor Lang, do you agree?
Yes, short break were good. Meanwhile, also I'm going to ask the student to log in for their attendance. I will get it done while we're having this 5 minutes break. Thank you so much. It's really informative.
Yeah.
I learned a lot from you as well.
Thank you so much. I appreciate. I'm looking forward to meeting you again. So in maybe 5 minutes, if it's okay. We are out of time. I'm going to cover case control study design, which is really important. And I would expect you to maybe have some publication using this study design. So if you are ready, please let me know.
Yes, doctor, we may start. Thank you so much.
Okay, perfect. About the previous presentation, please, if you have any question, let me know. I appreciate your questions. If I'm going too fast, please also let me know. If you need more information, also, please raise your hand. Here, just to show you some obvious example about ecological studies. This is one study that was performed by under the supervision of myself and 3 of my students. Basically, this is my professor, so not my student. This is mainly about COVID-19, mainly about the incidence of the disease, and body mass index, or BMI, and cholesterol. As you see here, we worked on global data. So no individual data was included in this study. We reported the whole data information for the populations from different countries. And as you see here, the same thing that I just showed you, okay? I wanted to say that these study designs are real. These are not fabricated. You can use them in your future design. Also, at the end of this study, I mentioned that these data are coming from population level, so we cannot, generalize our finding to at the individual level. This one is a cross-sectional study that I used to see the impact of different social and clinical factors on diagnostic delay of breast cancer using a cross-sectional study design. I want you, please, from now on, if you read an article and the design was cross-sectional study, and if the authors wrote, we found a causality, please do not believe it. As I mentioned, in cross-sectional studies, you just took a screenshot, like, a snapshot. We really don't know if the disease came first or the exposure came first. So do not believe it at first glance. And also, this is another one that I mainly looked at health behavior and late-stage diagnosis of breast cancer. And again, using a cross-sectional study design. And now we can move forward and go ahead for the next design that we have, which is about case control studies. Yes, perfect. Anyone knows something about case control studies? Yeah, about systematic review, experimental studies, and their differences. You really mentioned some interesting points. I really like them. Okay, good point. You mentioned that you control the variables. Okay, it can be. Anything else, guys? Please feel free. Yeah, just mention your opinion, even if it's not correct. Do not afraid of making mistake. This is okay. Just mention what you want. If you have anything to say about case control study design, I appreciate. Otherwise, I'm going to the next slide. So let's move to the next slide. So the quality of evidences generating from different study designs are like this. So if you are a policymaker and you are having two, for example, papers, one is randomized control trial or cohort study, and another one is case report, and you are going to make a decision, which one you will choose, which one you will rely on. For sure, if the methodology of the study is fine, for 100% sure, you will go for randomized control trial or cohort study, and you can make a decision according to the finding of these studies, not like case report or case series. Okay, we are moving up. We have already discussed about ecological studies, case control studies, cross-sectional studies, case report, case series, and now we are going to discuss about case control, which is also an observational study in the category of analytical epidemiology studies. Okay, just to show you here, you can see where case control studies, where case control studies can be categorized. These are here. Non-experimental studies, individual-based. So your sample size are individual, not population. And in the under category of analytical epidemiology. We have already discussed this one, these categories, this one also. And now, case control studies. So I heard some nice points from you in our chat that you mentioned if we can handle exposure or not. If you are going to perform study designs, please look at this key point. Are you going to decide for exposure or not? If you are not going to decide for the exposure or exposures, no difference at all, then you will go for observational studies. If you have comparison group, it's analytical design. If you don't have any comparison group and you are going just to report the case, it's descriptive, like case report. On the other hand, if you are going to manipulate the exposure, for example, you are going to use like a food supplement, and you are going to, for example, give it to some patients, and you are going to use a placebo or drug-like, or like, not a real, how to say that, not the real, for example, drug or supplement, then you are controlling the exposure. This is experimental studies because you are manipulating the exposure. Okay. This was a key slide that I showed you. In cross-sectional studies, at the same time, we looked at exposure and outcome. However, in case control studies, we are going to look at outcome and then go back and see the exposure. Why these patients with breast cancer, some of them have late breast cancer stage, but the others, they have early stage breast cancer. Why? What happened? Then you will go back and seek for the exposures. Okay. So the next slide that I have for you here, I tried to make it really simplified for you. As you see here, in case control studies, you have two groups of people, one with no disease and another group with disease. And you will go back and search for their possible exposures. For example, in the example of breast cancer, if they had medical insurance or not. Some of them may do not have medical insurance, but the others they have. And you will see if having medical insurance or if having access, for example, live in the rural areas, countryside areas, or in the city areas, if this is a factor that affecting later stage breast cancer or not. Move up here, please. In cohort studies, your study will start with healthy population. Remember my first example, I said, suppose in your class there are 20 students and Professor Lang will see the effect of physical activity on your health outcomes, or maybe any outcome, after 10 years, after 5 years. Okay, so remember, case control studies will start from patients and go back to exposures. On the other hand, cohort studies will start from exposure, having exposure or not having exposure, physical active or not physical active, and we will seek for the outcomes of the exposure. So I tried to really here simplify it for you. I said case control, E, exposure. Just remember it, okay? I'm not going to say memorize it. And in cohort studies, we are looking at outcome. In case control studies, we report odds ratios. In cohort studies, we report relative risk. I will cover this odds ratio and relative risk later on. There are some brilliant examples about case control study in the history of medicine. For example, in 1940, Professor Oshner, he was a surgeon in New Orleans. He realized that while he was operating some lung cancer patients and he was writing medical history from the patient, he realized that the majority of patients with breast cancer are reporting cigarette smoking history. Guys, at the moment, this is funny to say that smoking is associated with lung cancer, but at that time, this was not funny. This was a really nice finding. Just by observation, he realized that, okay, patients with lung cancer, they are reporting history of having cigarette smoking. Something sparked his mind with a new idea. He hypothesized that cigarette smoking was linked to lung cancer. He was trying to convince the society, the companies, that they are, making huge benefit from cigarette smoking. He was going to convince everybody that cigarette smoking is a risk factor for lung cancer, but no one wanted to accept. It was funny. It was really funny for them, okay? And they said maybe Professor Oshner is kidding, to be honest. But no, according to this observation, he realized that, okay, some patients with lung cancer are reporting cigarette smoking. So based on this observation, do you think this conclusion is valid? And if you are Professor Oshner, what is your approach to convince the society and the companies that are making benefits from cigarette? What is your approach? Okay, if I am Professor Oshner, I will design a study. I have some patients already with lung cancer, and I will select a control group. I will select a control group without having lung cancer. And then I will ask the patient with lung cancer if they had history of lung cancer. And also, on the other hand, I will ask the healthy controls if they also have any history of cigarette smoking. Then I will compare both groups to make a conclusion. I will show you how to calculate it. Another top and brilliant example in the history is in 1940s by Professor Gerg. He observed that several infant and young children, they have some eye problems, which is cataract. And this was not accepted for Professor Gerg, that why at this age we have cataract, because mainly we are expecting this eye problem at an older age. This was an idea. He realized that when children were not born, it means when the mothers were carrying the babies, I mean, during the time of pregnancy, the rubella outbreak was really catastrophic at that time, or measles. In Germany, call it measles, okay? At that time, he realized that the outbreak of rubella was really, really catastrophic while the mothers were carrying their babies. And he was like, what's happening? What happened to this kid? And it was until that time that he realized that rubella can be transferred to children through their mothers during pregnancy. And this can make a huge problem for children and causing cataract. Then at that time, he tried to find the mothers with getting rubella, and those, they had no history of becoming sick as a result of rubella. And then he tried to compare these two groups, if their children are having eye problem or not. So keep in mind that at that time, we had no knowledge about any causal association between virus, mainly about rubella, and its teratogenic effects on children. So as you see, this study and this huge finding in the history of medicine was based on observational study. So which study design you will go for? In this case, you already have some patients, and you are going to see the reason for this disease. Definitely, you can choose a case control study. Why? Because you are going from outcome to exposure. Remember my previous slide that I highlighted several times for you. Another thing that I'm going to share with you. Suppose you are a clinician and you are seeing some patients with certain type of cancers, or you are going to the society or to the lab or to, you know, whatever, okay, or wherever, and you see certain type of a disease, and you are asking them about their previous history, and some of them are proposing having exposure with particular chemical like arsenic, then maybe you can generate this hypothesis in your mind that maybe arsenic is related to this disease, this cancer. And how you are going to confirm that? Then you will find one group of patients you have already. You will go for a healthy group also. So you have two arms, and you are searching for their previous history of exposed to arsenic. So this is the nature of case control studies. So the next slide. The next slide, as I already mentioned, you can choose the cases and controls, and you can examine if they have exposure, for example, to arsenic or not. And at the present time, we are looking at their past, at their history of having any exposure. Okay, next slide is in line with my previous example. You had some cancer patients, and you have comparison group. They don't have cancer, but maybe they have heart disease, kidney disease, or whatsoever. But your control group must be free of the disease of your interest. If the group of comparison, if your cases are having cancer, your control group cannot be cancer patients. Guys, last year I was reading a paper. It was published in a really top journal, and they were working on bladder cancer, and their control group, some of them, they had, if I'm not mistaken, breast cancer. This is not valid. Your control group must be free of your, you know, disease of the cases. Bear in mind this one. Bear in mind. Okay, so not to choose any control for your study. Then we are going back to their previous history, and then we can compare two groups and then draw a conclusion. Just to show you again, cases, controls. Have the disease, they don't have any disease. I mean, this disease, okay? Then we are searching for if they had any exposure or not. Exposure or not. And then we compare both groups. So, as I already mentioned, case control studies are categorized under the category of observational studies. And here we are going to examine the causes and why, what happened, the causes of the disease, okay? Because we already have the disease, and we are going to search for exposures. In the study design, be careful. Individuals who have the disease or outcome of interest are cases. Individuals without the disease, but similar to the cases. Here, let me say something to you. You cannot choose, for example, cases from elderly, for example, men, but controls from, for example, teenager girls. This is absolutely biased. So they should be at least, you know, same in some characters. I will show you later on, okay? Research process is identification of cases. You have to be really careful about identification of cases. If you, for example, go through a hospital and ask the patient if they have cancer or not, this is not true. You cannot say that by asking patient, we identify the cases of cancer, for example. Or I asked the patient if they had any heart disease problem or not. You must have proof for your declaration. If you are, for example, going to categorize these patients to, for example, having cancer or cardiovascular disease or something, you need to see the medical examinations from the patients. But the worst part ever in case control studies is control group. If you submit any paper to any journal, basically the top ranked journals, the main comments that you will receive from the editor and the reviewers will be about the control group. This is like my experience, hands-on experience. You will be bombarded by lots of questions about control. So be really meticulous, be really careful about selection of control. So if I'm going to ask you one question about, for example, in your final exam, I will ask the main part of a critical point in case control studies. What is the main point? Is selection of control. So I already covered these two, so I'm going to the next slide. So according to the literature, cases are a person or maybe a group of people that having particular disease or health disorder or any condition, like, for example, depression or like anything, or like any disease or any health problem. And the control is in the comparison group, okay? They are different in terms of that disease of our interest. So some key features about case control studies. We know that both exposure and outcomes occur before a study starts. Yeah, you see that some patients are having cancer and they have already have or maybe doesn't have access to health insurance. So we have no control over it, okay? We have no control over exposure and outcome. Both are already happened. So basically, we have different type of case control studies design that I'm not going to cover, but if you would like to read them, you can simply search on the internet about nested case control studies. Okay. And mainly this one, I'm typing in our chat group, but I don't have access. Okay, guys, I wanted to just write for you here in our chat box about nested case control studies, but I cannot type anymore. Okay, no worries. So far so good. Is everything clear? Perfect. Perfect. So, okay, thank you all. Thank you all. Amazing. Perfect. Perfect. So you are going to measure your exposure. If they already have, for example, medical insurance, if they have any history of exposure to, for example, smoking or whatsoever, you can use different instruments. Like you can perform an interview, or you can design a questionnaire that should be valid. I'm not going to open how the questionnaire should be and must be, which topic you have to cover, and how you can validate your questionnaires, because this is about another topic, another lecture. So I'm not going to dig into this part. Also, you can just simply go and see the past records from hospital records or employment records. Just have a look at the patient's report and you can find your exposures, any kind of exposures. It can be sex, age, BMI, also family history of cancer or whatsoever. So some features about case control studies. So the subjects are basically based on the condition that they have the disease. We call them cases. and free of the disease, we call them control. Both groups will be compared in regard with having or not having exposure to certain characteristics, and it can generate a really robust hypothesis about causal association between exposure and the disease. So there are some steps to conduct. Let me just move this part and somewhere, okay? Yes. A step to conduct case control studies. First of all, you have to establish the diagnostic criteria. As I already mentioned, that you cannot just simply ask patient, are you, for example, suffering for disease or not? You must have to follow some, logical instructions. For example, according to ICD-10, I think you already, all of you maybe you know that about ICD-10. This is the classification of the disease, okay? Standard classification of the disease. So sources of cases, simply you can find cases from hospital or from general population. For example, you can go to the society and find if some people are suffering from depression or not, okay? For selection of controls, however, there are different sources. You can select from hospitals, from relatives, for example, from their siblings, from neighborhoods. And the size of controls is really interesting and should be taken into consideration. If the number of the cases is about 50 cases, we can use one control for each case. If you are going to write a paper about case control study, please remember this one. Please remember this one because this can help you a lot. If the number of cases is below 50 generally, we can use 2, 3, or even 4 controls. Somebody knows why we are doing so? Any idea? I would like to hear from all of you, please. Any idea why the number of cases is about 50, we can use just one control, but when our sample size for cases is lower than 50, we can use 2, 3, or 4 controls. Any idea? Okay, maybe this is, yeah, please.
Student, try to be more responsive, please.
Yeah, maybe this is a difficult question. Okay. Yeah, in this case, we are going to show some robust evidence to the society. But as you see here, 50 cases is really not much. And then if we are going to interpret our results according to just 50 case and 50 control, maybe the power of our study is, yeah, perfect, more accuracy. Yeah, maybe the power of our study can really increase a lot. So one reason, as if I pronounce your name, I'm sorry for that. Chayan, as you mentioned, in order to increase the accuracy and the power of our study, we use maybe 2, 3, 4 controls per each case. Yes, and why we are doing so, why we are doing this? Because in some cases, this is really not possible for us to find like 20, how to say that, 100, 200 cases. This is maybe a rare disease, okay? Maybe this is a rare disease. And then we don't have enough cases. However, guys, you have enough access to control group because they are not patient. So by doing so, you can increase the accuracy and the power of your study. Bear in mind that, do that, and apply it in your case control studies, okay? By the way, one point here I would like to mention for you guys, case control studies are really a golden approach for rare diseases. Why not cohort studies? Because you cannot wait for 10 years, just waste your life to see 10 patients or 50 patients after 10 years. It's not logical for us, okay? So by doing so, using case control studies, I mean, we can save our time, and we can perform a study on rare disease using this kind of study design. It's interesting that I wrote the answer for you guys. I don't know why you are not paying attention to my question. I here wrote that to increase the power of your study. So please be alert. Okay, in case control studies, we mainly go for odds ratio that I will open up later for you. So I already discussed this one. Definition of cases should be valid, okay? And eligibility criteria, you can use both incidence cases or new cases, and also prevalent cases, both new and old cases. And also for source of cases, you can use hospital or general population, as I already mentioned for you. Selection of controls, also you can use different sources like hospitals, relative, neighborhood, general population. So this is a key point, must be similar to the cases, except for the disease under study. I'm highlighting these points several times. Just have a look at this table. Each of sources has some advantages and disadvantages. For example, about hospital-based sources, yeah, we have really easy access to the patients and control both of them. But here we have Brixton bias that I will say what is the Brixton bias, okay? I will show you later. I have all of them in the next slide, okay? Recall bias is a huge problem in this kind of studies. And I will also open up this one for you later. And maybe you can also have a look at population-based and neighborhoods, because we are out of time. Just, I want you please to take a look at this table. Okay, how many controls are needed? One for large studies, but for if your study is not large enough, use 1 case, 2, 3, 4, or multiple control. The main challenge that I already mentioned is about appropriate way to select control, because this can reduce the bias in your study. The benefit of using case control studies is to test the hypothesis that the disease of interest is caused by an exposure. For disease with long latency period, we can use this kind of studies. To study rare diseases, as I already mentioned, they are really easy, rapid, cheap compared to cohort studies. Sometimes we require few subjects, not much. We don't have to follow just CT or like 1,000 of patients to see the effect, for example, of one exposure, as we are doing so in cohort studies. We can examine multiple exposure factors for one single disease. Remember this one, remember this one. As I mentioned, we have some patients with cancer and some patients without cancer. And you are going back to see what were the main reasons for cancer. By having a questionnaire or like medical files, like interview, you can ask 1,000, not 1,000 basically, but maybe you can ask 100 questions about different factors. For example, if they had any exposure to chemicals like hair colorings, like estrus, like oral contraceptive pills, like having how many children they have, age of, for example, first delivery, and so on. Okay, then you can compare these factors all together in 2 groups, control groups and case group. And then you can draw a conclusion. So in these kind of studies, fortunately, like ecological studies, also we have minimal ethical problems because we are not manipulating our population, or we are not applying any exposure, just we are observing and reporting. Another nice thing about case control studies, it's no attrition problem, because you already have your patients and you can ask them, and you don't need to follow patients for next round, okay? You don't need to follow the patients for 10 or maybe 5 months, okay? Because we are doing so in cohort studies, okay? So no attrition problem we do have in case control studies. This is a good point. However, limitation of case control studies. Please remember, if you found any study that is case control study and they are reporting incidence or prevalence, please do not accept that. Just in nested case control studies, we can report incidence rate or prevalence rate. I wrote it here. I hope you can just see it in my screen. I cannot send it. I don't know really why, but no big issue, no worries. Oh, my apologies. So as you see here, if you are reading an article which is case control study and reporting incidence and prevalence, be skeptical about that, about the design. And as I mentioned, it's not suitable for rare exposure, but for rare diseases is fine. The problem of bias, selection bias and information bias that I promised you to mention. Anybody knows what is the meaning of bias? Mainly in epidemiology. Anyone? So I think no, maybe, okay. Very selective, good point, good point. I think one side, oh, okay, perfect, perfect. Professor Lang, I'm happy that you have some brilliant students. Fascinating. Okay. Bias. What's the meaning of bias? Bias is any systematic error in the determination of the association between exposure and the disease. As you see here, I wrote systematic error. Type of bias can be recall bias, selection bias, or by confounding factors. I'm going to open it for you because we have less than 15 minutes time. So bias in case control studies can be mainly assigned in these categories: bias due to confounding, selection bias, survivorship bias, healthy worker effect, memory or recall bias, Bergson bias, and interviewer bias. Guys, please feel free to reach these biases and Google them in the internet and see the meaning of these biases. Each of them needs maybe at least 5 minutes in order to be explained to you. Because we are out of time, I really want you, please, to just Google some of them that I'm not going to cover. I will cover selection bias, information bias, and maybe Bergson bias for you, but healthy worker effect and survivorship bias, I want you to Google and to read more about them, because later on you have to know if you are going to be an epidemiologist or a researcher. Okay, guys, selection bias. The cases may not represent those in the general population. Very selective. As you see here, this is the good answer also. This one also, one side over another. As you see here, the cases are not representative for general population. So it means your study is biased. For example, here, the health awareness about the association between cardiovascular disease and smoking influences the selection of cases. Smokers at the time of onset of CHD are more likely to attend to the healthcare facilities than those with similar symptoms who are not smokers. because they think maybe this smoking is affecting their health. This results in an artificially high proportion of cases of CHD among smokers. Guys, non-smokers are not coming to the medical center, okay? And the results is biased. The results are biased. Why? Because your population are mainly smokers. Or another point. Suppose you are having a ward at your hospital, which is mainly for patients with heart disease and, for example, like pulmonary diseases. Okay, this ward is specifically for this patient with lung disease and heart problem. So if you are going to just select the cases of CHD from this ward, you are, going to bias your selection. Why? Because those who are having problem and issues with their lung are most likely to come to this center, to this ward. And these patients are already faced with maybe some chemicals that affected their lungs or smoking or whatsoever. So any association between smoking and CHD here is artificial. It's not real. So be careful about the selection of your cases and control, mainly control. Memory or recall bias. The person who is diagnosed with any disease or cancer is more likely to remember about the exposure than non-exposure. Suppose you are asking a mother that whose baby is suffering from like a malignancy or a cancer. If you ask the mother, do you think you had a history of chest X-ray during your pregnancy? She's trying to remember every single thing that was happened to her during pregnancy. And this is most likely that this mother with having like a baby with problem is more likely to remember everything compared to a healthy mother. So this is a recall bias. If you are going to avoid recall bias, you have to simplify your questions, not to dig into questions that really need patience and control to think about it specifically, because this can cause recall bias. Okay, another thing that I worked as the manager of HIV/AIDS Research Center, and I touched this one really. When you ask patients with HIV about their unprotected sexual intercourse, this is most likely that those who have HIV remember really well about unprotected sexual activities compared with those that having no HIV. So as you see here, this is like memory, recall bias. They cannot really remember good, or, control group cannot remember very well, but the patients are really curious to point out and single out every exposure that they had. Regarding breakdown bias, this is mainly happening in hospitals. A brilliant example is cigarette smoking and peptic ulcer. Peptic ulcer patients are asked not to be a smoker anymore because it's really, really dangerous for their health if peptic ulcer patients stay with smoking. So if you are going to select patients from this ward, you definitely have some patients that their smoking habit is already reduced. They are not a smoker anymore. And then you will realize that, okay, the smoking has no significant effect on peptic ulcer. This is not true because you have breakdown bias. You already caught smoking for these patients, and you cannot declare that. You cannot examine the effect of smoking on peptic ulcer anymore, because this already diminished. This already was deleted from your study. I hope it's clear for you guys. Another thing that I would like to mention is confounding factors. Confounding factor is a factor other than this one suited in your study. It can disturb relationship between the exposure and the disease. I will show you by a chart or a figure for you, so no worries at all. Here, one example, association between family size and frequency of iron deficiency anemia may be due to other factors such as pattern of diet, infectious diseases, socioeconomic condition, and any infection. So you cannot say that if the family size is higher, the frequency of iron deficiency is higher. The family size itself is not the main reason. Maybe the main reason is another thing. Maybe it's infectious diseases in this family. Maybe it's socioeconomic status in this family. Maybe it's about poor diet in this family, and so on. So here, the confounding is like this. To be confounding factors, two conditions must be met. Remember this one also. It's really vital for your presentation, for your articles. This is exposure and outcome, and there is a third variable here. This third variable is associated with exposure and also associated with outcome. Here, without being the consequence of exposure. So this is not the consequence of this. Independently of exposure, not and intermediately. So you see, independent of exposure, the third exposure that was like poor diet or infectious disease among large family size can be associated with the outcome. Outcome was iron deficiency. So here is exposure. There is a confounding factor. So large family size is exposure, and condition or outcome is iron deficiency anemia. And other factors are confounding factors. Here also another factor, you may say that coffee is related to CHD, but coffee itself is not risk factors because those who are smokers are more likely to drink more coffee, okay? And here smoking is affecting coffee and smoking is related to coffee, okay? These two are really collinear. These are really in line with each other. So if you say that coffee is affecting CHD, you can be skeptical about this association and you can find that, okay, do you think all the factors are considered? Maybe the smoking is the main reason, but we ignore this smoking, this part. If you ignore smoking, so your results are not clear. So you have to be really careful about confounding factors. In order to avoid confounding, there are several ways that we can reduce the potential of confounding factors. One of them is matching. By matching, for example, age. You can match cases with controls. For example, age is a big risk factor, significant risk factor for cardiovascular diseases. So we already know that age is a risk factor, okay? So if you are going to do a research, first try to match the cases. For example, one patient with age, for example, 40 to 50, one control also with age of 40 to 50. Same in the rest of the population. So I'm going to show you, just to ignore this part, because I would say that we have different type of matching, like individual matching, frequency matching, that I'm going to show you in this slide. If you are going to just do individual matching, you are like having, for example, one cases, one control, similar. Another one, another one. The matching factors can be age, can be socioeconomic factor, or any factor that you think is highly affecting your disease. You can match it, okay? Or sometimes it's not possible to find really a specific case for each patient. For example, you have a patient age 55, but you cannot find a control at the age of 55. In this case, you can group using, group or frequency matching. You can say that, okay, in this case, the patients age 50 to 60 will be in this category. For example, I have 6 of them, and then I will find 6 control in this range, 50 to 60. Okay. Matching criteria, variable for matching should be chosen based on their potential to confound the exposure outcome, such as age, sex, socioeconomic factors, and other relevant factors that are highly impacting the disease. We have some benefits from matching, reduce the confounding, and enhance validity of our results. I have some PowerPoint about some slides about data analysis. Not sure if I can continue. Professor Lang, please, if you are online, please let me know if I continue. If not, just I would ask a student just to go through them and try to realize how we can calculate odds ratio.
Yeah, this part is really important. I believe it will be good to continue. Thanks so much, Dr. Mostafa.
Perfect. Of course, my pleasure. Yes, really, indeed, it's really, really important because when you are reading any article in this category, case control studies, you must have to know odds ratio and the logic behind odds ratio. Okay, in data analysis for case control studies, we are going to calculate exposure odds calculation for both cases and control groups. So we are seeking and looking at odds. Exposure odds for cases A, C. Here, suppose we have the disease here. If they have the disease present or they doesn't have. Exposure, for example, smoking, if they are smokers or not smokers. As you see here, cell A, it means disease or patients who already have exposed to a smoke. So it means both disease and exposed. So we call them concordant. Let's move to the last one, D. They are not patient. They don't have any exposure. We call them D, okay? Also concordant. Here, they have exposure, but they are not diseased. They are not ill. On the other hand, cell C, they have the disease, but they have no history of exposure to their risk factor. Okay, exposure odds for cases means A, C, A, C. As you see, we are seeking and looking at exposure among cases. On the other hand, exposure odds for control. Exposure odds for controls, it means B, D. Okay, if you are going to calculate odds ratio, you can simply multiply concordant divided by discordant. AD divided by BC. Hopefully this is so far it's clear for you because I'm going to dig into with more detail now. If you have any question, please raise your hand. Okay. So I wrote here A, B, C, D just to make it simplify for you. The rate of exposure among cases, the rate of exposure among all cases, I mean. It means A divided by A plus C, A plus C. And the rate of exposure among controls, it's obvious. It's B among all controls, B plus D. Okay, hopefully it's clear so far. So measure the extent of association between the risk factor and the disease. We will calculate odds ratio. As we already calculated and showed, we can simply multiply AD concordant and divided by BC discordant. So this is the logic that why we are doing so. the odds among cases and the odds among control. And finally, we will reach a number. This number can be higher than 1 or lower than 1. So your threshold or your basement is 1. Is the odds ratio OR that you found is greater than 1, it means the exposure had a relationship and a risky relationship or positive relationship with the outcome. For example, the OR for smoking is 2. It means smoking can increase the risk of cancer 2 times compared to non-smokers. However, if the OR is lower than 1, it's protective. Suppose iron supplementation and, for example, colorectal disease. You will reach the OR equal, for example, 0.7. So in this case, we say that iron is OR for iron exposure and cancer risk is lower than 1. It means iron supplementation is protective for colorectal cancer. It means 0.7 times lower risk for those who use iron supplement. I'm going to show you one clear example here. Suppose you have 20 patients and 20 controls. History of sun exposure is 120 among cancer patients, and history of non-sun exposure is 80. History of sun exposure among control is 40, non-sun exposure is 160 among control. Okay. Here, I would like to open something for you. The independent variable here is sun ray. Dependent variable is cancer. Confounding factors can be several factors like sex, age, and chemicals, occupation, and so on. And let's calculate odds ratio. If we are going to calculate odds ratio, we already wrote here that we have 100 patients who had exposure, 80 patients, no exposure. And for control, 40 patients, they have exposure, 160 control, no exposure. You can simply multiply 120, 160, divided by 40, multiply 80. The odds ratio that we have calculated is 6. Anyone knows what's the meaning of this 6? Just to help you out. The odds ratio is 6. It means sun exposure, okay, may increase the risk of basal cell carcinoma of skin 6 times more compared with those who had no or less exposure to sun. Is it clear for you guys to calculate OR, odds ratio? So the key points mainly are, to compare it according to 1, if it's above 1 or under, or lower, I mean. If yes, risk. If lower, is protective. And the calculation was really simple. As I said, concordant and discordant, you can divide and then calculate OR, but you don't need to do that using, like calculator or by hand. You can do it using different statistical software like Stata, SPSS, or Python, and so on. If I had the chance to join your university, for sure, I will improve all of you to do research and also to analyze your data without any problem. I'm going to finish by saying some points. Advantages of case control studies: easy to carry out, rapid, inexpensive for rare disease, no risk to the subject, no ethical consideration. It means several etiological or risk factors can be examined. So, as I said, no attrition. This is the wrap-up slide. Almost. These advantages we have recall bias. This is really big issue in case control studies. So selection control and recall bias are two main big, disadvantages in this kind of study. Incidence cannot be measured. As I said, if you read any article that says the incidence of, for example, this cancer is high in this case control study, do not believe it. Do not believe it, because these kind of studies are not able to provide you incidence and prevalence rates. And sometimes representative of case and controls is really, really difficult to say that our cases and controls are representative of our whole society. Guys, if you are going to write any paper, any article in observational studies, I mean cohort studies, case control studies, and cross-sectional studies, I'm the editor of some journals, so I'm giving you some really valuable points. Please, 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 please follow these instructions. And in the first line of your method section of your paper, please write that this study was performed according to STROBE. And if you are able, you, your team, the whole professor at the university, I would suggest you to download the checklist. And if you are going to submit your paper to any journal, if you are going to be professional, please also submit this checklist to the journal and to the editor, so that the editor and the reviewers will see that, okay, they already know the basic of the design. They already know how to write a paper. So please, please do not forget this stroke. This is my taking home message for you guys, for you, for Professor Lang and your team. Please remember and keep in mind that for observational studies, please try to read and write your paper according to this one and submit the checklist to the journal. And finally, I thank you so much. This was indeed a really nice time for me to meet you all. I'm happy for that. I wish I could see your faces, but it was not possible. If there is any question, yes, please ask me.
Yeah, thank you so much, Dr. Mostafa. It's very, very informative. Like you say, you like compress one day's to 2 hours, which is, and also you have spent so much effort in preparing the slides. Thank you so much. I really enjoyed your lectures and also pick up a lot of new points. So students, please take notes of all this very valuable knowledge shared by Dr. Mostafa. So we're looking forward to see you again next week for the second part of the epidemiological study design.
Of course, for the second part, I would like to go for a really, really big presentation about clinical studies, also about cohort studies. And for the first time, I would like to open systematic review and meta-analysis for my students, just for your students, because I'd really love to empower them to know everything about this kind of studies. Mainly for my students at the master level and bachelor level, I would not go for systematic review, but I would like to cover this. So guys, please feel free to read about cohort studies, also randomized control trial, experimental studies, and systematic review. And if you had any question, I'm here to help you. And Professor Lang, thanks again.
Thank you. Yeah, we catch up again soon. So I don't want to further delay because you have been given 2.5 hours talk. So thank you so much. We see you again. Okay, thanks everyone for attending. See you.
Yeah, thanks everybody. Have a nice day. Bye-bye. I see you soon.
Thank you.